Good evening, everyone, and welcome to the presentation of the high frequency paradox. My name is Gary Brigham, and I'll be presenting the webinar tonight. Just a little bit of background on myself. I've been in private practice in Scottsdale since 1983. I currently serve as both the dedicated Invisalign and Propel instructor, as well as adjunct professor of orthodontics at the A.T. Still Orthodontic Graduate Program. I also serve on the clinical advisory board as a member for Propel Orthodontics. One thing that I never include in my curriculum vitae, but I think is a little bit relevant for tonight, is that while I was serving at the University of Illinois Medical Center, I had the opportunity to become part of a PhD program in biological chemistry, of which I've completed 1 year before the government decided to send me to Tokyo, Japan for 2.5 years. And after I'd been in Tokyo for a while, I decided I didn't want to go back to cold weather, so I came directly to Arizona. And consequently, I'm stuck with a half of a PhD, which is, you understand why I wouldn't include that in my curriculum vitae. However, I never lost that interest in biochemistry, and actually my thesis was going to be on the biochemistry of bone. And so I've sort of carried that interest throughout, and so this is one of the reasons why I've been very engaged in the research, especially over the past 5 years. I find it compelling and exciting, and I hope to present or touch some of you with regard to some of the changes that have occurred, especially in the past few months. So why accelerated orthodontics? Why this interest, especially in the past 5 years? Well, for my own part personally, I found that there's been some changes in the way patients are presenting themselves for treatment. In the past couple of years, I've noticed that patients are now presenting new treatment demands. And one of the most significant demands is they're expecting shorter treatment lengths that coincide with their personal expectations. I can remember as little as 7 years ago, it was still just generally accepted that patients expected 24 months of treatment. They thought that was the standard. And then about 5 years ago, it became, everyone agreed that the standard was 18 months. In the past couple of years, they've been coming in and patients have been expecting 12 months of treatment. And they seem disconcerted when they find out that it's going to be a little longer. And very recently, I've actually had patients say that they wouldn't want to engage in treatment unless it's around 6 months. So I think this is a trend. At least it's been a trend in my own practice, and I think that this trend is probably being experienced by some orthodontists, at least from the conversations that I engage with. So I think this is something that we're going to be faced with, and I think that we're going to have to embrace this because I don't think it's going away. So what do we know about MOPs to date? Well, MOPs is definitely understood. The biochemical mechanisms of action have been documented, and I think they're pretty much well agreed upon. That what happens with MOPs is as soon as there's a release of chemokines and cytokines, it instigates the rankle, which is simply a protein that sits on top of the outer edges of osteoblasts. Once the stimulation by the chemokines and cytokines is to release that rankle, it goes to find its receptor, the rank receptor, on pre-osteoclasts. And once that connection is made, it stimulates the pre-osteoclasts to form osteoclasts, and then the race is on. Though what makes MOPs particularly special is there's also a significant release of MCSF, which is macrophage colony stimulating factor. And that is special because that particular protein stimulates hematopoietic stem cells to actually merge and become macrophages that can go directly on to become osteoclasts. So in that particular situation with that protein, it just bypasses the rankle formation of osteoclasts, and therefore in a MOP situation, you just have a greater bone turnover. And this is one of the reasons why when you're using MOPs, you can exchange aligners every 3 to 4 days rather than 7 days. You can't do that with pulse vibration, but you can get pretty close in some situations. The other thing that's definitely understood is the physiological mechanism, and it's basically this. In order to stimulate osteoclastic activity and osteogenesis, you have to mechanically induce microfractures. Those microfractures create the cascade effect, the chemical effect that I just alluded to with the chemokines and cytokines, and that generates the osteogenesis. Now, although this is on pulse vibration technology, I really have to address this because this article just came out in 2017 and it's received an inordinate amount of attention. And one of the reasons why is because it's being pointed to as proof that there's no evidence that MOPS works, and this is summarily incorrect. There's some significant problems with this AJO article. And one of them is that, first of all, the inflammatory markers were not measured. And this has just been a pretty significant protocol because this would demonstrate evidence that whatever they did either worked or didn't work. More importantly, they reported themselves that they used a mini screw, a TAD, and they inserted it 3 to 4 millimeters deep to account for soft tissue thickness of 2 to 3 millimeters. Well, if your soft tissue thickness is anywhere around 3 millimeters and you're only inserting your TAD 3 millimeters, you're not into the cortical plate. Not only that, but according to Jun et al. In an article from 2012, they found that at 3 millimeters and 5 millimeters from the CEJ and at the apex of canines, just of the bone just distal to the maxillary canines, they found an average thickness of 1.5 to 2 millimeters, with some canines demonstrating thickness of 3.3 to as much as 4.5 millimeters distal to the canines. If that's the case, I think it would have been prudent and appropriate, if you're trying to determine the efficacy of a MOP procedure, to use CBCT analysis to determine the thickness of the bone that you're attempting to penetrate. And finally, and you can see how this is getting redder as we go along, what they used was an R-House mini implant screw. They used a TAD to conduct the MOPs. And on top of that, 2 of those TAD failures were actually reinserted. Now, I know there's been arguments over and over again, but a TAD is not designed to conduct MOPs, and I'll get into that a little bit more. Then finally, they admitted that they were attempting to duplicate Alicani's work. Well, if you're trying to mimic his work, Alicani used 100 grams of force when he was retracting canines. Al-Kebsi actually did that by 1.5 times and up to 150 grams. I don't understand that at all. And more importantly, the whole point of the study was to replicate Alicani's work. In addition, they only measured that force at the beginning, and they failed to measure it at each appointment. So these are significant flaws in my estimation with regard to attempting to prove whether MOPS was, ethical or not. More importantly, what they chose was they chose the R-House TAD. The R-House TAD has been shown to create the lowest cortical strain of any TAD on the market. It's one of the best TADs on the market. Although there's 3 types of metal to be used in TADs, R-House favors the titanium, and even if you use one of their stainless steel TADs, which does the most microfractures, it's titanium coated to minimize microfractures. Design matters, and especially with TADs. These mini screws are specifically designed to limit damage to bone. And with MOPs, you're doing the exact opposite. In addition, according to Kim's, Kim's excellent textbook here, he indicated that small differences in diameter can have substantial effects. That's why the TAD's at 1.5 millimeters. The pinpoint for MOPs for the Propel procedure is 1.6. That's a significant difference in regard to the amount of damage. In addition, most mini implants have a surface treatment to provide less bone damage. So to actually use a TAD to conduct MOPs is in the wrong direction. It's not paying attention to what the whole purpose of MOPs is. And to actually add insult to injury, now we've got Kevin O'Brien on his blog, with his little article here saying that he said that this was just once again evidence that MOPs does not work. Now, buried in his blog is just this little blurb that said, interestingly, he actually acknowledged that in order to, when they applied the MOPs, they used mini screws. However, he said, I'm not sure, if this makes a difference, and he was asking for an opinion leader from a Propel advocate. But the bottom line is this. I know from experience and from just talking to other orthodontists, oftentimes they just read the head article and they go right to the conclusions. And the bottom line is this. For an academic of his imprimatur, with the global reach that his blog enjoys, to actually place a biased spin on MOPs as evidenced by his clever reference of the rock band The Who with his title, We Won't Get Fooled Again, without conducting his own due diligence, I think it's highly irresponsible, and frankly, it's quite disappointing. I really regard him as an opinion leader, and for him to make this gross error and to create the possibility for misleading orthodontists that are really interested in acceleration, I think, as I said before, it's very disappointing. So yeah, the critical difference, if you get nothing from this with MOPs, is this, that TADs are designed to limit microfractures and to limit any inflammatory responses. They're designed to have maximum pull force, all right? And with regard to the patented stainless steel threaded tips, which are uncoated to provide maximum microfractures, these tips are designed to get the greatest inflammatory response. This is what MOPs is all about. So what are the clinical advantages of MOPs? In my own part, obviously they're great for accelerating complicated cases such as this and trying to get this patient out of crossbite. And I found that they're great for addressing challenging individual tooth movements. But since this trend has occurred that I alluded to with regard to patients wanting to be on a treatment, I find it's great for even these patients that come in and expect to have their treatment completed in 5 to 7 months. And let's just give you some examples. Patients such as this will actually come and say that he would rather see his teeth wear away than put braces on. And so a gentleman at this age would come in and he said, it doesn't really bother me and I'm not really concerned about the aesthetics, although I do recognize the attrition that's going on here. And so he said, I'll be glad to do Invisalign, but I don't want to be Invisalign for 6 months. So this is what they're laying down on the table. So I said, all right, now that I've got MOPs, I can do this. And this is what I've been doing. So this is what we're doing. And this is what's been happening with MOPs. Yeah. So we were able to get all of our treatment objectives completed and doing this within 5 months. Same thing with this gentleman. And so what do you think happens? He goes back to work and his colleagues see that. And so he comes in and said, I've never really been happy about this, but I really don't want to be in treatment for 6 months. Is there any way that I can do that thing that you did on my colleague? And I said, absolutely. So now I'm getting patients that are coming in and asking for Invisalign and MOPs. And so within 27 aligners, we were able to finish them in 3 months and 3 weeks and meet all of our treatment objectives, which are a broadened arch form, a good interincisal angle within the physiological limit, and some semblance of a smile arc to improve his smile. And then patients such as this, he's a young professional, he's in professional school, and he realizes that he's going to be graduating in 8 months and he wants to have a smile that matches his profession. So, in a case like this, since I know that we're going to have to be addressing these peg-shaped laterals, I told him right up front, it's not going to be 1 MOPS, it's going to be 2 procedures. And he said, that's fine as long as I can complete this in 8 months. So that's exactly what we did. We put him through his first round of aligners. And after we went through 28 aligners, flipping him out every 3 to 5 days, his first round is completed in 3 months and 2 weeks. And at that point, we took off all the attachments, whitened him, and then we built up his peg-shaped laterals with composite, and then we went ahead and rescanned him. And when the aligners came back, we performed a second MOP procedures, and now we want to get the best arch form that we could hand for him, focus on getting him a good smile arc, and at the same time, making sure that we get an interincisal angle that's within the physiological limits. And so after a total of 56 aligners throughout his entire treatment, we were able to make his deadline, complete his case in 6 months and 2 weeks. And throughout his treatment, it was a 3 to 5 aligner exchange program with 2 MOPS procedures. Now, you might take a look at this case and say, oh, this is easy. Well, Almost. When you've got an anterior open bite where the open bite is due to bimaxillary protrusion, those are, everyone welcomes those because that's very easy. All right. All it is just retracting the maxillary incisors and you've closed the open bite. But what happens when you've got an anterior open bite of 2 to 2.5 millimeters, but you've got an interincisal angle that's within the physiological range? What we don't want to do is do that protocol of just retracting the incisors, because you'll steepen the incisal angle and that invites premature anterior contacts, which leads to a posterior open bite. So the reality is, for me, these cases are challenging, and they were a constant source of irritation for me in treatment until MOPs came along. Because with MOPs, I find that I get better extrusion, especially when I'm trying to get vertical extrusion, and I get better gripping power of the lateral incisors particularly. And so I can actually say with a degree of confidence that we can get a very good result with better incisal display, good smile arc, and still respect the interincisal angle within a reasonable time frame. So after 80 aligners and going through a full range of aligners plus one refinement, we were able to finish them within a 10-month period on a 3 to 5 day aligner exchange. Why the 3-5 day aligner? Because patients don't always wear the aligners 20 hours a day. So they're instructed not to go to the next aligner until they're tracking perfectly all the way across the board. So basically, I'm dumping it in the patient's lap in terms of that type of decision. I find that MOPS has been great, and I never thought that in my own practice that I'd have 28 patients this year that have already gone through Invisalign and they're coming back for a better Invisalign result. This gentleman is a professional and he's been out of his Invisalign treatment for 6 months and he wasn't happy with the result. He said he's in the camera a lot and he'd like to have a better smile. And so he's willing to do Invisalign, but he doesn't want to go through Invisalign for the initial 24 months that he did on his first round of Invisalign. So having had experience with MOPS, I said, I think that we can do this under 12 months. And he said, well, I'm willing to do that. And so once again, trying to get a better smile for him. And with 55 aligners, we're able to complete them in 8 months, in 1 week, with a much better incisor display, a better smile arc, and still respecting the interincisal angle. And then there's a patient like this. She didn't say much. She came into the office and said, all she said was she was embarrassed by her smile. Obviously, she had had orthodontic treatment in her youth, had 4 permanent bicuspids taken out, and she literally collapsed. So she came in with bimaxillary arch constriction and the associated crowding that's always seen with these cases. And practice is full of these cases. So at that time when she came in, we were still exchanging the aligners every 2 weeks. So you don't know what exactly it is outside of a guesstimation until you actually do the treatment. So when the box came back, I did the math. She came in and I told her that she'd probably be finished in about probably 18 months. And she proceeded to break down and cry. And so I looked up and she said, "It's not you, Dr. Brigham. I was hoping to be done in time for my daughter's wedding." And I asked her when her daughter's wedding was, and she said 9 months. And I told her, I sat down, and since I was just beginning to get involved with MOPS, and I told her about MOPS, and I said that that was the only way that we'd have a chance. And she asked me if I could guarantee that, and I said no. I said, but I said that at least we'd have a fighting chance to meet her deadline. She said she'd just do anything to not embarrass her daughter's wedding pictures, which I thought was kind of cute. All right, so we went ahead and we did MOPS from 6 to 6 in both arches to get a better arch form, to get the smile arc, and to unravel these crooked anteriors. And I have to tell you that this is one of the best Invisalign patients I ever had. This woman was on a mission. She wore those aligners 22 hours a day. So for a patient that I originally told 18 months of treatment, she finished in 6 months exactly. In fact, she even had time to whiten her teeth and to go to the wedding and be very proud of smiling with the wedding pictures. So very happy with that. Another patient that came in and proceeded to put her through Invisalign, got her all dressed up with attachments, and then she told me she was leaving to go to Mexico because she was a Spanish teacher and she was brushing up on her Spanish. So I told her, I gave her explicit instructions about tracking, and I said if she felt that there was any concerns to take a selfie and to text it to me, and then I would make any judgments and call her. Well, I'd never heard from her. So I just assumed that treatment went along rather swimmingly. And so she presented, gave her the whole box, and didn't see her for an entire year. When she came back, she presented into the office with this. All right, and so I asked her, I said, didn't you notice that this was going sideways? And she said, yeah, she said, but I didn't want to slow down the progress of my Invisalign treatment. So I gave her three choices. I said, we could do a crown on this, or we could do fixed appliances, or we could do another round of Invisalign, but she was going to have to do MOPs on this tooth. And so she elected that to do another round of Invisalign and do MOPs. So literally, I had to bring this tooth out, turn it around, and then bring it back. 52 aligners and flipping them out every 3 days because once again, she was a woman on a mission, and we were able to finish this treatment in 5 months and 2 weeks. And I have to tell you that out of those 52 aligners, 43 of them were just basically focused on moving this tooth, all right? But I've on occasion had situations like that where I've had a renegade tooth or two, and by just conducting MOPs, it's been able to get me out of these difficult situations and get the kind of finish that I was hoping for. So having that, let's put this to bed and let's get down to what we're supposed to be talking about tonight, and that's high frequency acceleration using high frequency vibration in orthodontics. So what do we know about vibration to date? Well, we know that vibration's been known to be anabolic for decades. That's been in the medical literature for years, and it's been used. We also know that the biochemical mechanisms of action are there's a decrease in rankle with low vibrational frequencies, which are used in medicine today. And that's where you get that bone building effect. We also understand the physiological mechanisms of action. Basically, the vibrational effect is to increase osteoblasts, increase the number of osteocytes, increase myocytes, and even increase the number of mesenchymal stem cells. We also have been shown through the medical literature that vibration is biomechanically safe, that kept at low magnitudes of 1 G-force or less, that it's been used for 10 years in medicine and even more. And we also know that it's been used in various medical devices for the past several decades at various G-forces, usually around 1 G-force or less. In fact, since I've been using or actually following the literature for the past several years, I've actually taken advantage of it, because back about 7 years ago, it was noted that I was a little osteoporotic in my pelvis, probably due to all the running that I used to do in my youth. And so I noticed that these low-grade, low-level vibration actually stimulates bone cells to increase bone density. So I went out and got a power plate, and I've been using it daily for the past 7 years. And I was pleased to find out that the bone density is back, and I will literally lie on it, kneel on it, exercise on it, step on it, and it's very easy, and it's become the most important piece of apparatus in my workout regime. So how can vibrations support tooth movement? What do we know? What's vibration's impact on orthodontic tooth movement? Well, we know that's been methodically investigated for the past 10 years, but the literature hasn't been very encouraging. I mean, we have just as many advocates claiming that vibration accelerates orthodontic tooth movement, and then we have an equal number actually saying that there's no effect on orthodontic tooth movement. However, according to Guyette, using the grade analysis, which has been basically accepted in terms of determining or judging the quality of evidence of any literature, just judging by all this literature, it appears that the quality of evidence as judged by grade is assessed as very low, probably because it's simply all over the place. So what are the principal problems and criticism with all this this literature? Well, first, there's huge methodological flaws from paper to paper. Not on all of them, but some of them are just so huge that it renders the research literally useless and not important in one aspect or the other. The other is the problem, and probably the most significant problem, is you can't get any consensus. All these research papers are using just different frequencies, different accelerations, and different durations. So it's virtually impossible to make any type of consensus readings or make any comparison studies because it's impossible to compare. On top of that, some of these studies actually vary the tooth movement. Some of them are judging it based on movement of incisors, other them are based on canine retraction. And then, of course, there's the differences in the modality of orthodontic tooth movement. There's a huge difference between making a judgment on aligner therapy as opposed to fixed appliances. So if anyone's been actually engaged in the literature, if you're confused, you should be, especially when it comes to high frequency vibration. And you should be confused up until now, because there's been a significant change in the past few months. And that's because of Alakani's article. And this is what the whole crux of this presentation is. Because Alakani sat down, did all the review, looked at all the criticism, and actually addressed every single issue. So the investigation objectives were to determine the effect of high frequency vibration on not only the rate of tooth movement, but also on alveolar bone in general. And also to determine whether the mechanism by which high frequency vibration affects orthodontic tooth movement. The parameters that he assessed, he went through every single parameter of every single study that's been done, from 0 hertz to as much as 200 hertz. He checked the acceleration at 0.1 grams, 0.5 grams, and what seems to be becoming the standard of 0.1 gram. He also analyzed the duration of exposure, whether it's 5 or 10 minutes, and he also investigated the effect of direct and indirect application of vibration, as well as orthodontic tooth movement with varying orthodontic forces. He covered every single parameter and every single aspect of what's been investigated for the past 10 years. The most comprehensive study I've ever read. So what were his findings? Well, in the absence of orthodontic tooth movement, specifically, high frequency vibration has been shown to improve bone density greater than low frequency vibration. So it appears that different frequencies deliver simply different results. And these differences have been shown to be statistically significant. Also show that with high frequency vibration, the high frequency nearly doubled the bone volume versus low frequency, just simply using it at 5 minutes a day. This has very significant implications. So if anybody that's using a high frequency vibrator, when you're finished with treatment, you continue using it for retention. So right now I'm having my patients use it for additional 3 months, 5 minutes a day, to as best as possible to increase the bone density and to help augment the stability of the orthodontic result. So we also found that in presence of orthodontic force, high frequency vibration plus orthodontic tooth movement decreases bone density greater than orthodontic tooth movement alone. And this difference, this decrease in bone density is significantly statistically different. And it's significant. We also found, he just simply found that high frequency during orthodontic tooth movement elevates inflammatory the baseline and significantly decreased bone density versus orthodontic force and controls alone. So when we're looking at high frequency vibration and the catabolic effect occurs when there's an orthodontic force. It creates an inflammatory condition. The target tissue is the periodontal ligament. The responding cells are osteoclasts. They result in bone resorption, and the effect is accelerated tooth movement with an increased magnitude of tooth movement in terms of the distance. You can see the implications, especially even with differential anchorage. When, in terms of the anabolic effect, when you apply high frequency vibration without any orthodontic force whatsoever, the physiological condition is you get a response, an increase in osteocytes and osteoblasts, and you get an increase in bone formation. So the implications and the result is improved retention after orthodontic treatment and an improved osseous integration after implant surgery. More importantly, the implication is this: every time you take out a bicuspid, research shows that you lose as much as 52% of the level of the alveolar bone, which is one of the reasons why it's critically important to close those extraction spaces as fast as you possibly can. Using or applying high frequency vibrations has been shown to preserve the bone after tooth extraction. So this is very significant for when you're taking out 4 bicuspids. Also, high frequency vibration results in significantly greater tooth movement than low frequency vibration. So different frequencies deliver different results. And these differences in results are statistically significant versus low frequency and with orthodontic tooth movement alone. So, and in this particular case for this study, the low frequency was 30 Hertz, the high frequency was 120 Hertz. So he also found that with vibration frequency and time constant, orthodontic tooth movement is more responsive to higher G-force. So that means that the 0.1 millimeter G-force has a greater response that is statistically significant with just simply orthodontic tooth movement alone, or these other 2 frequencies. So it's important to point out that G-force is not a force. I don't want anybody to think that this is force in grams, but it's simply an acceleration that actually comes down to 9.8 millimeters per second squared, all right? And a G-force is just simply a force that's acting on a body such as a tooth as a result of acceleration. Very significant results. In addition, Alicante found that high frequency vibration with a high G-force for simply 5 minutes delivers significant and safe increase in tooth movement. So it's not necessary to use it more than 5 minutes. However, there is a difference. Although this difference is not significant, there's still a difference in tooth movement. So this would suggest that it might not be a bad idea to have a patient use it 5 minutes in the morning and 5 minutes at night, and still be within a tolerance that's safe and tolerated in terms of the number of exposures of vibration to the patient. And quite honestly, I've been using this for a while, and I find that patients are doing fine with it, and they don't seem to mind. And some patients even asked if they can do it more than once a day. So high frequency vibration prolongs and maintains osteoclastic activity in the presence of orthodontic force longer than just orthodontic force and tooth movement alone. And once again, this is proven to be statistically significant. So high frequency significantly increased the number of osteoclasts in the presence of elevated inflammatory condition. And high frequency significantly prolonged the effect of orthodontic forces on osteoclastic activity. So after this is biological proof in my mind that high frequency vibration produces greater orthodontic tooth movement beyond just the supposed mechanical effects of enhanced inliner seating. Very significant. So with this ongoing research from these 2 institutions, they've methodically isolated and investigated each vibration variable to scientifically identify a safe and effective high frequency dosing. So to this day, it seems that 5 minutes is the gold standard here. In other words, you get the most bang for the amount of vibration that's applied. 10 minutes is safe, and although it just gives a modicum of greater tooth acceleration, I think 5 minutes is actually now become the standard. It appears that 0.1 millimeters of G-force is the maximum acceleration tested and seems to be the greatest amount of tooth movement. And the high frequency has been shown to be significantly greater and more effective when any of these other lower intensities and frequencies are tested. So let's just take a look at some cases, all right? So this patient, I don't really want to be correcting cross bites at the age of almost 14, but sometimes you have no choice. So in this particular case, the focus was on getting her out of crossbite as fast as possible. So in these cases, I'll use a Hyrex expander. I use a memory expander, so you can go crank away and the force is expended over a period of time, so the patient can tolerate the force. So in this particular case, the patient was expanded actively over a 2-month period of time, and then we held it for 4 months to hope to get some bone filling into the suture that was split. But even at this point, patients already bothering about how much longer I'm going to be in treatment. My response is, we haven't started your Invisalign treatment yet, but this girl's in a hurry. So I made her purchase a high frequency vibration device. And that allowed her to exchange the aligners every 5 to 6 days, depending on how often she wore the aligners. And her aligner wear was anywhere from, according to her, 18 to 20 days. So 18 to 20 hours per day. So what I do in these cases, I just teach the patients what good tracking is, make sure that they understand that they don't go to the next liner until they have good tracking. I always point to the lateral incisors as the problem teeth. And she was able to finish her aligner therapy in 6 months. So her total treatment was 12 months if you include the Hyrex appliance. And I'm not unhappy with the root parallelization that we got in the case. And we were able to get her into a interincisal angle well within the physiological range, no posterior open bite, and a good width. So what I'm getting now is patients coming in along with their parents telling me that they'd like to have Invisalign, but he won't be able to wear any elastics, which is problematic in a case like this. And the reason why, they always point to sports and they have to use the mouth guard, but they're not playing sports 24 hours a day, but the parents are just adamant that, just do what you can because he just can't wear elastics. So this is an excellent time to be considering doing, high frequency vibration. So on these particular cases, I said, in order to meet that type of requirement, then you're going to have to use some type of acceleration device. So going through 72 aligners and 1 round of aligners and 2 additional refinements, we were able to finish him in a reasonable time frame of 14 months and 2 weeks, with him exchanging aligners every 5 to 6 days. And being able to get the broadened arch form, a reasonable smile arc, and good interincisal angle without any elastics. And then same thing when the patient comes in and she has concern about the dark buccal corridors, not happy with her smile arc. She's definitely not happy with this chiclet for a veneer. And she actually expressed regret about allowing the dentist to do that. So I said, well, what we're going to do is we'll just take that off and we'll get these teeth aligned, and then we can go back to the dentist and get a brand new veneer. And she said, I'm willing to do that. But once again, she's in a hurry. She doesn't want to be in treatment for 18 months. So I said, well, we're going to have, and some of these patients are very reluctant to do an invasive procedure such as MOPs. So these are perfect patients for high frequency vibration. So we gave her a device, gave her instructions, and she followed through. And after going through 58 aligners, exchanging the aligners every 5, 6, or 7 days, according to the patient's judgment and her observation of tracking, we were able to finish this case in 13 months. So, I mean, just do the math. This would have been far greater. We're able to cut these patients' treatments down by anywhere from 3 to as much as 12 months. There's another patient. He's actually a cardiologist, and he said he noticed that this was getting worse. He was very concerned, and this is what I see on a daily basis: bimaxillary arch constriction, poor interincisal angles that are starting to create, from occlusal trauma and fremitus. They're getting gingival recession. This certainly isn't from toothbrushing, and he's also getting significant intrusion of his not only the lower incisors, but of the maxillary incisors and the enamel that's palatal to the surfaces of the maxillary incisors. So they're willing to go through the accelerated treatment. So in these particular cases, he's going to go through, I'm recommending MOPs as well as high frequency vibration. And I'll explain why at the end. But bottom line, these are excellent cases. He's a busy individual. He's got his own patients. Didn't want to come into the office too often. He wanted to minimize his office visits. And after going through 83 aligners, able to get him a much better smile presentation, take care of his arch form, and clean up his anterior crowding, and get these teeth out of harm's way and hopefully get some type of improvement of the gingival composure. And so these combination therapies are significantly helpful, and they're able to keep me within a range that's reasonable and that meets the patient's expectations of treatment. He actually thought that with Invisalign alone, he could be finished in 12 months because that's what he heard, but not with these type of treatment objectives that I've just elaborated upon. And here's a significantly deep bite, anywhere from 80 to 90%, and very poor incisor display. These are challenging cases for me because with this deep bite, I'm actually going to have to extrude her maxillary incisors to give her a greater incisor display. That means that the majority of addressing this deep bite has to come through proclination of the incisors and a lot of intrusion of the lower incisors. And so I've gotten to a point where I'll tell patients, I can do this case and we can do this in a very reasonable matter of time, but I can't do this without MOPs, and you're going to have to supplement that with a high frequency vibration device. And the response is okay. So what I'm getting when I get questions from orthodontists of how do you get patients to do MOPs? I've actually gotten to a point where I just tell them, I'll do this case, but I'm not going to do it without some type of acceleration because you'll get frustrated and you'll burn out. I'll get frustrated and we'll both walk away unhappy. So I feel so much better when I've able to offer them, and in some cases tell them that I don't think we really want to do this case without acceleration. And their response is, okay. And so out of 79 aligners, on a 3 to 6 day aligner exchange supplemented with high frequency vibration, we were able to address the deep bite, increase her incisor display, fill in the buccal corridors, and give her a little bit better smile arc, and as well as address the anterior crowding. So having had this experience with these type of cases, I've actually attempted to take on more challenging cases. And once again, telling patients that I'll be glad to take an attempt at this because she's been told for most of her life that this is double jaw surgery. She already had orthodontic treatment, I think, and the orthodontist had taken out actually 3 bicuspids because she was missing a lateral, so they did a canine substitution, which I think worked out very well. But she's only actually occluding on her first and second molars. This is highly problematic. So all they can do is just, I can tell you that be glad to do this. It's going to involve a lot of elastics. It's going to involve MOPs and a vibration device. And the interesting thing is she's an emergency room physician. And so that became a problem because she actually said, well, I'm not able to wear elastics all the time. So I'm not finished with this case, but I can tell you that after 76 aligners and only 9 months into treatment, on a 3 to 5 day aligner exchange, I feel that even if she fails with her elastics, I can reboot her and just do significant more IPR from bicuspid to bicuspid, and then get a lot of more lingual root torque on the lower incisors. And I think I can get her a good interincisal angle, distalize these a bit more and improve the occlusion, and get out of this case within a reasonable time period of around 14 to 16 months. So these are cases that I wouldn't even considered, as much as 3 years ago without doing something like MOPs and high frequency vibration, simply because the patients burn out. So my days of, and believe me, I've had those days of 3.5 years of orthodontic treatment tackling these cases, they're over. Because at this point in juncture, I'm able to show a lot of pre and post-operative treatment to these patients and tell them that the only way to address this case is with MOPs and high frequency vibration device. So, to sum this up, the science on MOPs is very explicit. And what's also explicit is that TANs are not designed for MOPs. Yet I'm sure that in the future, we're going to see additional studies where someone is attempting to see whether MOPs works or not, and they're going to use a mini screw. Mini screws are not designed for microfractures, period. And in the absence of force, high frequency vibration is more anabolic than any low frequency vibration. We also concluded that high frequency vibration with force produces greater rate of tooth movement than low frequency vibration or with orthodontic treatment alone. And high frequency vibration increases inflammatory mediators and maintains their response longer than orthodontic treatment alone. High frequency vibration also produces the fastest, safest orthodontic tooth movement, and has been identified as the standard frequency variable moving forward from this day forward as a result of Alicani's work. And in addition, with time and frequency variables constant, bone cells are significantly more responsible to a higher G-force. All right, and with higher G-force and frequency around this range, 5 minutes appears to be you get the maximum effect with a minimum time commitment. When I tried a device with a low frequency, my success rate was only 10% because I didn't tell patients. I had a way of determining their cooperation, and patients just went ahead and just lied to me. So I abandoned that and went to something that I only used 5 minutes a day, and my success rate is significantly greater because apparently patients can put 5 minutes a day into that commitment. Having methodically isolated and tested each variable, Alicani's proven biological proof that high frequency vibration produces greater osteogenic effects and orthodontic tooth movement beyond just the mechanical effects of enhanced aligner seating. And when electing to incorporate vibration devices into practice, the frequency of vibration is critical. So I'd like to wrap this up with just my own clinical experience with high frequency vibration. I have found personally that with excellent patient cooperation, it's significantly possible to exchange aligners every 4 to 6 days, depending on the amount of hours that they get in and also the degree of difficulty of the case. I've also found that with less patient cooperation, which is really the standard in my practice, where patients are really only wearing the aligners 16, 17, sometimes as little as 14 hours a day, I found that high frequency vibration enhances aligner seating and reduces the number of on-tracking incidences that I used to experience several years ago. So in that respect, it does provide a secondary treatment acceleration effect simply because I'm finishing a little bit sooner because I'm doing less refinements. All right. I've also found that high frequency vibration significantly prolongs the effects of MOPs. The question that I commonly get is, how often and how long is the MOP effect? And the answer to that is it depends. For the most part, I find that for the first 3 months after MOPs, patients are able to flip out the aligners every 3 days. Sometimes by the end of the 3rd month, they're flipping them out every 3 to 4 days. When you start getting into the 4th month and the 5th month, I find that the patients have now extended to every 3 to 5 days. When you apply high frequency vibration, find that they're able to flip out the aligners every 4 to 5 days for up to as much as 8 months before they start going to 7 days. So it's been a real good adjunct, and so that's why I've begun to package MOPs with high frequency vibration devices. I've also found that in a significant number of patients have told me that once they apply a new aligner and they apply the high frequency vibration for 5 minutes, they find that it significantly reduces this discomfort often associated with tooth movement, especially when it's associated with aligners. So this is a personal decision on my part, and it's going to be a personal decision on your part, but I can tell you, when I take a look at what other people are doing in their profession, and Wayne Gretzky, I like this quote because it just said, you miss 100% of the shots that you don't take. I'm a toe in the water type of person. I didn't embrace acceleration until I was absolutely certain that I could actually look a patient in the eye and tell them that you will get a result. And I've been enjoying the benefits of this for quite a long time now. So for my own part, I have to admit that in acceleration in my practice 3 years ago, acceleration, I can say, significantly influenced my practice. Today, I think acceleration, especially with aligner therapy, defines my practice. So thank you. I appreciate your sitting in with me for this webinar, and I will be glad to address any questions that you might have. And once again, I don't see any questions coming up on the board. So just in recap, once again, don't throw, if you're using a high frequency vibration device, then by all means, don't throw it away. Don't let the patients discontinue it after you get them into retention. My suggestion would be to have them continue to use it 5 minutes a day, and with or without their aligners in the mouth. I tend to have them do it without the aligners in the mouth or their retainers in the mouth for an additional 3 months, which will help secure their retention, and I think you'll get a better retentive result. And the research is there to definitely back it up. So again, I don't see any questions. So finally, again, thank you for joining me in this webinar. It's been a pleasure to sit with you, and I hope to meet you in the future.